Hello, everyone. You are live with Johnathan Maness, CEO of Maness Veteran Medical. And today we're coming to you with a talk about the Moleculight. And when you talk about products that are absolutely changing the world right now in the wound care arena, this is just one that is just at the top of the list that you have to know about. And Maness Veteran Medical's mission has always been bringing these cutting edge technology products to the very forefront so anyone at the VA and the DoD can learn about it, have access to it very quickly. Today, I have a special guest, Dr. Charles Andersen from Madigan Army Medical Center. And he is going to be doing a demonstration today and going through the in and out of the Moleculight, how it works, everything you need to know there. But I'm just so thankful to have him here today. I'm at the end of the demonstration, we're going to have a back and forth, a good conversation, just going over some questions. And anyone that has any questions at all about the Moleculight today, please throw them up in the comments. We will go through the majority of them at the end of this live stream and just spend time answering your questions directly. But without any further ado, I'm going to go ahead and bring in Dr. Charles Andersen. Hello, Dr. Andersen.
Hi, Johnathan. Thank you for the introduction.
Well, thank you so much.
My name is Chuck Andersen. I'm a vascular surgeon by trade, and as Johnathan said, I work at Madigan Army Medical Center. At Madigan, we've had a limb preservation initiative for over 25 years. It's something we started after a simple observation. The observation was that we were doing too many amputations in patients with diabetes. Our limb preservation initiative is a team approach. We have vascular surgery, the vascular lab. We have two highly trained podiatric surgeons that do only limb preservation work. And we have a full-time wound care service. Currently, I am chief of the wound care service at Madigan Army Medical Center. As Johnathan pointed out, when we're dealing with limb preservation, the Moleculight is truly a life-changing and amputation prevention technology that has now become a critical part of our limb preservation initiative.
Dr. Andersen, if you would, I'm going to go ahead and open up the PowerPoint and get straight into the presentation, okay?
Very good. So we're going to talk about the utility of point of care fluorescence for the detection of elevated bacterial burden at an Army Medical Center. Key in that title is point of care. Disclaimer, it's the top part of this is very important. I work for the US government. I work at an Army Medical Center. And what I'm going to talk about this evening is my case studies, my opinion, and not the policy of the Army or the US government. So there's been some very interesting changes in the patients that we see, not only in the DoD and VA healthcare system, but universally. The population has become more elderly, so that the era, for example, in the wound care arena or in the limb preservation arena, of seeing patients with what we call pure ulcers or pure wounds, that era has pretty much disappeared. Our patients have many coexisting diseases. When we see a wound, many times it's a mixed wound. It can be, for example, a patient with a diabetic foot ulcer, but oh, by the way, they're on chemotherapy, they have associated vascular disease, they have the other illnesses that impact the ability of wounds to heal. One of the differences, especially in the VA healthcare system, is patients can come a long distance to be seen in a VA healthcare system or a VA hospital. It's impractical for those patients, once they're seen and evaluated, for the provider to say, well, we've taken a culture, we want you to come back tomorrow, we want you to come back in a week to have a dressing change. Many times these patients travel for hours, sometimes even longer, to get to a VA hospital. So that if we have a modality like the Moleculight, where you can get point of care information that critically leads you in decision making, then that can lead to the initiation of proper care and avoid unnecessary trips back to the VA hospital. So this is one of my patients. When you look at this photograph, this is a patient that I've followed for a long time. This patient has very, very severe venous disease, has recurrent venous leg ulcers. So when you look at this wound, there's certainly a significant wound. The skin around that wound is irritated, indurated, somewhat erythematous. So the question becomes, what is the appropriate dressing? Is this stasis changes? Is this an infection? So we'll come back to this case, but oftentimes trying to make decisions only on the clinical criteria can be difficult. That doesn't mean we don't use the clinical criteria. History and physical, very, very important. And a careful examination and characterization of the wound is also very important. What the Moleculight does, it gives you additional information then can change, modify what you do for this wound. So this is a demonstration of the device. So this is a handheld device. What you see on the left side over here is with the device, you're able to obtain an image. One of the very important features of this device is that all the data that you obtain on patients is recorded in the device, and the device you can assign each patient a tracking number. So if you're patient 235, for example, as we did today, then when you go into that patient's file, you have immediate access to the information that you previously obtained on that patient. The device also has the ability that you can measure the wound and document that so that you can see whether, again, you're making progress. This is the fluorescent part. So this red area is the fluorescence that indicates that there's a bacteria burden both in the wound and the tissue around this wound. So back to the picture that we opened the presentation with. What you see here is not only fluorescence in the wound, but you see this indurated area around here is highly fluorescent. So we would say, based on this image, that this patient has bacteria that is spread into the surrounding tissue, and we would treat this with antibiotics like a cellulitis. So this gives us information that there's bacteria within the wound, and that there's bacteria in the tissue around the wound. So in addition to the appropriate debridement and appropriate choice of dressings based on the fact that there's a heavy bacterial burden, this patient also would be initiated on systemic antibiotics. So here we are in the clinic. So we're obtaining our initial image. Then when you're doing the fluorescent part of the study, that is the actual bacteria, the lights are off, and you're able to then scan that wound. And what we saw in the scan was that there was bacteria. What I'm doing now is using that information that we've obtained with the scan, and I'm performing a curette type of a debridement. What we can do then, once we have finished that debridement, is we can then rescan the wound. to see if we've removed the fluorescence or the bacteria around the wound. Now, in this particular patient, this is a patient with a diabetic foot ulcer that we're also using biologic tissue. We feel very, very strongly that if you put biologic tissue on a colonized wound, that you're just wasting a lot of money. And as all of you know, some of these products cost as much as $2,500. So that prior to the placement of any expensive biologic tissue, we make sure that there's been adequate debridement, that we've removed any bacteria as judged by the fluorescence, and then we would proceed on with the application of the biologic, appropriately offload that patient and apply a total contact cast. When this patient comes back, every time the total contact cast is changed, we again scan that wound to make sure that we're not putting a patient back into a total contact cast that has a significant bacterial burden within that wound. So we use it every time we change the total contact cast, and we certainly use it every time we're considering application of a biologic. Today in clinic, a very good example, we were using a fairly expensive, or had planned on using a fairly expensive biologic tissue. We scanned the patient. Not only was there significant biologic or bacterial burden within the wound, but just like the case that I demonstrated a few minutes ago, there was significant bacteria in the tissue around that wound. So we aborted the use of that biologic tissue. That patient we debrided, and we also placed on systemic antibiotics. We also changed the follow-up plan. He's being treated for a chronic venous leg ulcer, but knowing that there's significant bacterial burden, we're going to bring that patient back a little shorter duration to change that compression wrap. So this is the flow in our clinic. We, as I mentioned, still go through a history. We assess the wound, and we always clean the wound, and then we scan the wound. And based on the scan, then we make decisions about what the next step is. That can, again, that information can help us as we're doing our debridement. And as I mentioned previously, after we debride, then we rescan. Then we move on with the appropriate intervention based on the information, both from the history, the physical, but the point of care information that we obtain with the Moleculight many times will modify what we do. We've looked at this with 2 times with patient studies, and in both times, approximately 20% of patients, it modified our plan. In one series that we just completed, it was actually a little higher than that. So this is a very good example. Again, this is a diabetic foot ulcer. You can see you would make your clinical assessment here. Certainly a wound that has some slough in, but it's hard to know if there is bacteria in that wound and exactly where the bacteria is. So this is the scan that points out that there's an area right in here where there's a significant bacterial burden. So this helped our decision making with the debridement. What you see here is we've completed the debridement, and now this is a repeat scan, which again, you don't see this area of fluorescence. And then this patient again was being treated with a total contact cast, and this is at week 6 that this wound is healed. It's my opinion that using this approach that we've been able to heal diabetic foot ulcers in a more timely fashion. The longer a diabetic foot wound is present, the more likely it is that you're going to get osteomyelitis, that you end up with an acute infection, and ultimately, unfortunately, can end up with an amputation. So the information that you can get modifies your plan and does give the potential for cost savings. And we have a study where we're looking at that, but especially in the VA, as I mentioned, where patients can travel for long periods of time. In our patients that have diabetes and oftentimes coexisting renal disease, you really want to avoid unnecessary antibiotics. And having the information that you could obtain with the Moleculight can lead to more selective use of antibiotics and can guide the therapy so that when the patients leave the wound care clinic, they have a longer term plan for wound care and can follow up at an appropriate interval, whether it's a month or some appropriate time. The other thing that's been fascinating with this therapy is that our patients become very acutely aware of the information that we're obtaining with the Moleculight. We always show them the information, the scans, and they know then why we're debriding. They want to see the scan after we're debriding. This is a quote from one of my patients. The images helped me understand what was going on. After seeing the images, I understood the seriousness of my wound. Very, very helpful, not only in education of patients, but I believe in promoting the kind of interaction that leads to compliance. We hear a lot about diabetic patients that are non-compliant. I think the more you can engage with your patients, the more information they have, and the more they understand the seriousness of a diabetic foot ulcer, the more likely it is that they're going to be compliant with things like offloading boots or total contact casts. In summary, I think patients that are coming to the DOD or VA healthcare system are particularly susceptible to developing wounds. They're an elderly population. And unfortunately, those wounds can lead to more serious problems, including amputations. If we can get additional information at the initial point of care, that helps us guide the use of various products, helps us in our debridement, helps us in the use of antibiotics, then we can provide better care to a well-deserved population. Thank you so much.
Dr. Andersen, thank you so much. That was outstanding. And people always say, Johnathan, why are you always fighting so hard? What is your drive? What are you doing? Well, Dr. Andersen, you know this. I'm an amputee. And fortunately for me, I become an amputee at the age of 25. So a 25-year-old can handle things a little different than a 40, 50, 60-year-old. And I see my fellow veterans at the VA, and I know my fellow DOD's members that are out there, they don't know what's all involved with an amputation. And when I see products like this that I know can save limbs by catching things early, it really means a lot to me to make sure that I give that effort to make sure that everybody that can hear this can hear it. So I just want to say again, thank you for that. But can you please elaborate a little bit about how you feel about amputation and how this product coming into the fold over the last few years is probably going to be able to save a lot of limbs.
Absolutely, Johnathan. And I'm very, very proud of what we've developed at Madigan. As I mentioned, we've had a limb preservation initiative for now over 25 years. And we've been able to document and we track very carefully our incidence of both minor and major amputations. And we've been able to decrease and continue to decrease the rate of major amputations. There are lots of factors that go into that. Very much a team approach is critical, but the ability to determine whether or not that there's bacteria in a wound is critical. So when you see a patient, for example, with a diabetic foot ulcer, there are two confounding factors that will take that patient with a diabetic foot ulcer to an amputation. One is arterial insufficiency. Now, we're fortunate to have a team that can manage that in the majority of patients with diabetes. The idea that, quote, diabetes have small vessel disease that can't be revascularized is not true. Most of these patients can be revascularized. But the other factor that contribute to amputations is infection. If you have an ulcer and you leave a colonized ulcer, for example, put them in a dressing and they go away for a week, oftentimes they will come back, and that bacterial burden now has led to significant infection, an acute infection. They have to go to the operating room for more of a debridement, so that being able to detect the bacteria early, appropriately manage that bacteria is a significant adjunct in preventing amputations. It's a game changer.
Outstanding. And, I am so thankful for our VAs. They've completely changed over the last 5 to 7 years. They are trying their best to get people in as quickly as possible. And they do give you the option to go out now if you can't get in. But even with that being said, the fastest you're getting into a VA is 2 or 3 weeks, at the earliest. And that's if your primary care can squeeze you in. It's very pivotal, in my opinion, to be able to have a good image when you go in there to the VA and try to make more of a determination that very first visit, so you can make a better game plan. So like you said, we're not traveling back and forth and losing that time, because that time of not knowing is where you get into trouble. Do you agree?
Well, I absolutely agree. And programs like this and companies like Moleculight and what you're doing, Johnathan, part of that is also educating providers and educating the public about the seriousness of diabetic foot ulcer, for example. And if the public understands that, it's I always look at it a little bit like a breast lump. There's been such a push and such education with the public that when somebody develops a mass in their breast, they're going to get into their primary care doctor because they understand the seriousness or potential seriousness. The more we can do as educators, as providers, to make sure the public understands that, so that when they have diabetes and they develop even a callus or a wound on their foot, they want to get to the doctor, and they're going to push until they get to the doctor. But then when they get to the doctor, they have to have the appropriate tools to determine whether or not there is bacteria, so that you treat that early, and you treat it appropriately, and you treat it aggressively.
Let's talk a little bit about that, Dr. Andersen. So, let's talk directly to the VA and to the DoD. How have you been able to implement the use of the Moleculight with your nursing staff, as a workflow? Has it been a seamless workflow, very easy? I mean, how would you describe that?
It's actually very easy. It now is part of it's just a standard part of our workflow. We're fortunate in that in the DoD and the VA system, money doesn't turn the wheel, so that when you're making a decision about the information that you can get with the Moleculight, we err on the side of using the device on a lot of our patients. And it just becomes, it's not a substitute for a good history and physical, and it's not a substitute for a good wound assessment. Certainly not a substitute for debridement. But to gain that additional information and make that part of your workload, it's very easy and not time consuming at all.
And one thing that I want to hit that we didn't really dig in too much, I don't think. Can you please talk a little bit about the history of the wound that you're able to capture with this device and how that is important as you carry a patient through, 5-10 years?
One of the potential problems with wound care centers is that many times the focus is on the appropriate use of dressings. That is important in wound care, but the history and understanding the etiology of the wound and making sure you're treating the etiology of the wound as well as the wound is critically important. Many podiatric surgeons have said it's more important what you take off from a diabetic foot ulcer than what you put on it. And that takeoff means that you're offloading. In a venous leg ulcer, compression is critical to the treatment. But many times the history, and again, we have elderly patients that come in wheelchairs and they'll have wounds. Unless you take the time to talk to the patients, oftentimes you don't develop an understanding of the etiology of the wound. A patient that we saw fairly recently, patient that is confined to a wheelchair, had a problem with spinal surgery, and was being seen for a wound on his leg. His wife is just a great caregiver, doing all of the wound care, but had been seeing a primary care doctor, and unfortunately, that wound just was not healing. Talking to the patient, the first question I asked the patient, "Why do you think you have a wound?" And he says, "Well, my leg rubs against the wheelchair." We patted the wheelchair, did the appropriate evaluation and treatment of his wound, and that wound was healed within a couple of weeks and has not recurred. So you have to take the time to understand what's causing a wound. Treat the patient, not just the wound.
And one last thing I want to hit here. So you mentioned avoiding placing expensive products with use of this device. If you prevent some of these serious infections, complications such as amputation, presumably that also lowers the cost of care. Can you comment about that?
Yeah, I think that when you get the information so that you can come up with a care plan, and you can be very selective based on that care plan and the information that you get both from the good history and physical and the additional information from the Moleculight, then you're less likely to be kind of shotgunning the wound. Many times we see patients that have received recurrent treatments with antibiotics, and what they have is stasis dermatitis, for example. If you elevate that leg, all the erythema goes away. And it's not cellulitis, but many of these patients have received many courses of antibiotics. And when they have renal failure associated with their diabetes, unfortunately, not only the cost of the antibiotics, but that can tip these patients into renal failure requiring dialysis. So it's critical that you're very selective with the type of treatment that you give these elderly patients. And the information you get with the Moleculight helps you be more selective with the appropriate products.
Well, Dr. Andersen, I always do this with my guests. First of all, thank you so much for your time and spending time with us to educate people tonight. With the last few minutes here, is there anything you would like to say? Any final words at all that you would like to put out there for the public?
Now, I go back to the breast mass, if you will. Oftentimes, I think we treat patients as people that know less than we know. I think we miss a real opportunity there. Patients can be part of the healthcare team. And I think the more information that we can give our patients, and the more that they then talk about that information with other patients, then you start to gain momentum with the public understanding the importance of the feet if you have diabetes. And I think Moleculight with their presentations and Moleculight with their patient care focus has given us the information that can help us reach the public, educate the public, and help with compliance and help prevent amputations.
Dr. Andersen, I hope you have a wonderful night. Thank you for your time.
Thank you.
So everyone, that was Dr. Charles Andersen out of Madigan, and I'm just so thankful that he spent a little bit of time here with us tonight and shared his thoughts. And I want everyone that's watching this video, we're going to share this out. Please share this with anybody that's in the wound care division anywhere in the world. Please just share this. We're trying to get the information from Moleculight out there. Any VA or DOD, reach out to me at the One Leg Bandit at Maness Veteran Medical. I will get you a quote right out. We are Moleculight's SDVOSB, and we're very proud to be that. So I hope everyone has a wonderful night. Again, email us and reach out with any questions. Thank you very much.